significa que ya vamos de ganancias con lo que estamos buscando lograr el día de hoy con este gran evento. Thomas, pues muchas gracias por la oportunidad de poder trabajar contigo y por todo lo que está haciendo por nuestro México. Tengo el orgullo y gusto de presentar al doctor Rodin, que es nativo de mi país donde nací, Canadá, y que está aquí en nuestro país, donde estamos, para compartir todo lo que él ha estado trabajando en Princess Margaret Hospital como jefe de la red de salud psico-oncológico sobre cuidados paliativos y también como profesor de la Universidad de Toronto. Muchas gracias, doctor.
Thank you very much, Felicia. I'm very pleased to be here, and I'm very impressed with the distinguished panel and the distinguished figures in Mexico that have come to take seriously the question of developing palliative care in Mexico. Palliative care began as a specialty because traditional medicine, mainstream medicine, wasn't attending to the needs of people at the end of life. And really, it had lost the skills that it had, because remember, all of medicine was palliative care 100 years ago. That's what all of medicine was. And as technology developed, we lost those skills. So it developed in order to address this problem at the end of life. But actually, we've also recognized that problems begin before the end of life. They begin at the time of diagnosis, and they begin in the course of terminal diseases. I think the least we can do is assure that morphine and other analgesics are available to people throughout the course of their disease. However, it is not the most that we can do. Actually, it's only a small part of it. Even to treat pain requires skill and training in the assessment of pain, in understanding the multiple causes of pain, in treating specific causes of pain, pleural effusions, and pain may not be the major symptom actually in many other diseases. We are in an Institute of Cardiology, and cardiology has recognized that the treatment of end-stage heart failure is palliative care. Palliative care in cardiology is often the treatment of heart failure. So I'll try to say something about the field of palliative care, about what might be important in its development, and about our experience in Canada, and which I would say about 15 years ago, it would have been, which was the bad color, Thomas? Was it red was the bad color? It would have been one of the bad colors, and I think things have changed over the last 15 years, 14 years, because of the investment in palliative care. Now, can there be such a good death? And do people distinguish? Our hospital and myself have been involved in consulting in various parts of the world, and when we've gone to these countries, in the Middle East and Asia and other places, we begin with the idea that these people must be very different and have very different ideas about what things ought to be at the end of life. And in each case, we've been wrong. And this slide is based on a systematic review we did of data, from qualitative data from many places in the world. In fact, what human beings want is very similar at the end of life. And relief of pain is only one of them. Relief of physical symptoms and pain is only one of the things that they want. Psychological well-being, this is a tragedy. Terminal illness is a tragedy for families. They want access to health care. They want to be able to have closure on their lives. They want to prepare for the end of life. And they want some say in the desired circumstances and location of death. And I like Thomas's point about choosing to die at home when one wants to, although there is a mythology actually that that's the only place to die, or that is necessarily the best thing. Home deaths can be awful deaths in some cases, actually. Now, what I'm saying is not radical, the idea that palliative care is something holistic and comprehensive. This is how the World Health Organization describes it. It is relief of pain and distressing symptoms in people at the end of life, patients and their families, but also attention to the psychological and spiritual aspects of patient care, providing a support system for helping people to live well until the end of life, and it's applicable from the beginning of the disease. In fact, when people have a short time to live, when people have 6 to 12 months to live, palliative care is as much about helping them to live and to live well as it is about helping them to die. We know that there are painful inequities, to use this phrase of Lamas and Rosenbaum, in the world due to many factors that make healthcare highly inequitable. Some of the inequities are actually due to stigma about disease, stigma about dying, stigma about morphine, and in fact the delayed presentation in many places in the world of terminal illness is why many people end up dying of cancer and becoming palliative. However, palliative care, I would qualify a little bit what some of the people have said is I don't think it's a simple field. I think it's actually complex to be skilled in managing the psychological, social problems, the complex medical problems of people who are dying, the diverse symptoms that people have. I think it is complex, but it is relatively inexpensive compared to many of our other high-tech interventions in many other fields. So I think there's possibility for us, even in less economically advanced countries, to do a great deal. One of the things that's been mentioned is the Prague Charter, put forth by the European Association of Palliative Care. It's in your binders, and this is something people can sign and hand in. And this is a declaration urging governments to recognize palliative care as a human right, to address these issues, to develop policies, and ensure that training and education. And I think that I want to emphasize that the education is a very important part. All of the policies, in order to be enacted, will require massive effort at training, which begins at undergraduate and postgraduate levels of people who will become palliative care specialists, but also of nurses and doctors who will be caring for patients with serious and terminal illnesses. So just one word about the trajectory. We now understand, and the World Health Organization reminds us, that palliative care can begin at the time of diagnosis. This can be the most distressing time. There's a large epidemiological study in Sweden, 6 million people, and actually the highest rate of suicide following the diagnosis of a serious cancer is in the first week after the diagnosis of the cancer. The rate of suicide is 12-fold higher, and the rate of heart attacks actually is 5-fold higher, due to the overwhelming autonomic arousal and distress that comes following the diagnosis. In fact, that might be the most traumatic event that many of us experience, the words of the physician. These are the words of one of the patients in our study. She said, "I was completely shattered, like everything fell beneath me. I'll never forget the doctor's words when he said it. I went to see him as one person and I left completely devastated." Now we teach physicians all of the technical skills required in the practice of medicine. Until recently, we've not taught them how to communicate bad news, even though this is one of the most common and difficult. We've expected or assumed that doctors would know how to do it, and they don't. It is a skill, just as much as the technical skills are important in medicine. Well, we decided, there's a lot of literature of people at the end of life, but we decided to look a little earlier. People following the diagnosis of cancer and having metastatic cancer. We looked at people with metastatic gastrointestinal lung cancer, and we recruited these people in the clinics. We recruited about 700 of them who were good enough to fill out a whole series of questionnaires and to be followed longitudinally. And we followed at least 400 of them to the end of life. And we wanted to see, could we predict who was going to become depressed, who was going to lose hope, and who was going to lose the will to live. And we wanted to see if we could understand the occurrence of depression in this population. This just shows the recruitment for the study. We screened initially more than 2,000 people and followed at least 400 of them to the end of life and assessed more than 700 at baseline. The first thing that we found is that these people were suffering from multiple physical symptoms. These are the walking wounded. On average, these people were suffering from 6 different physical symptoms. Some of them were suffering from as many as 12 to 14 physical symptoms. Now think about a day when you just feel nauseated or you just feel fatigued. Think how distressing that could be. Now imagine having 5, 6, 7, 8, 9, 10 different physical symptoms, how disturbing that is. We need to attend to all of these symptoms, not just the pain, but the nausea, the vomiting, the shortness of breath, which can be one of the most disturbing symptoms for people to experience. And what about depression? In the blue, we see, this is percent, we see about a quarter of the people at any one moment in time score above the cutoff are suffering from significant symptoms of depression. And a quarter are demoralized or suffering from symptoms of hopelessness. This means that human beings are resilient, that is 75% of people are not depressed at any one time, but we need to pay attention to that substantial minority. Now the red shows the spouses. The spouses were twice as depressed as the patients. And one of the important lessons palliative care, which this emphasizes, is that we need to treat the family system. There's a tendency in Western cultures to think that this is an individual problem, which it isn't. It's a shared problem, it's a family problem. When someone is dying or seriously ill, it affects everyone in the family. And the spouses, we need to help also because they're the main supports for the patient. So this demonstrates the model that we use a whole variety of statistical techniques to test, but it really demonstrates the multidimensional nature of palliative care and these factors that we need to treat in order to prevent people from becoming depressed and demoralized. We need to treat the physical symptoms. We need to support the individual, the self-esteem of the individual, the social connection, the spiritual well-being. Spiritual well-being is a fancy term. It doesn't always refer to religion. It refers to the sense of meaning. And I don't know about here, when you ask people in our country what is most meaningful to you, what is most important to you, what would they say in Mexico, do you think? Does anyone think? What is that? What do they think?
Family.
Family. That's what they say in Canada. That's what's most meaningful to people. And by the way, here's a historical cultural shift. I saw a qualitative study that asked patients, what are the 10 most important things to you at the end of life? And one of the 10 was being at peace with God. And another one of the 10 was having a good relationship with my doctor. Which do you think was number 1 and don't you think was number 10? Well, the doctors are higher than God. You know? This is a change. 100 years ago, it would have been being at peace with God. Physicians underestimate their importance to the patient, which those words of the patient reflect. The words of the doctor and the nurses are extremely important, can be extremely supportive or extremely traumatic. We need to teach people how to communicate. Now, about 13 or 14 years ago, we began to invest resources through the foundation of our hospital. I work in a comprehensive cancer hospital, treats about 40,000 patients. It's a major comprehensive cancer center in Canada. And they decided, I think, and I'm grateful for that, that not only did they want to invest in treating the disease and in doing research to cure the disease, but in supporting the patients through the disease. And we established, we have a psicosocio-óncología and palliative care department. It's at the same level as the Department of Radiation Oncology, Medical Oncology, Surgical Oncology, and we have psychosocial-oncology and palliative care. We began with 1 palliative care doctor in the hospital. We now have a dozen. We have an inpatient palliative care unit. We have a residential hospice. We have a partnership with the Home Palliative Care Center. And we have daily outpatient palliative care and psychosocial oncology consultations. If you want to do early palliative care, you must have outpatient palliative care. That's when you need to begin to plan for the future. That helps people avoid ending up in emergencies, ending up in emergency departments, and having crises which are difficult to manage. Now I'm going to present some data about the quality of death and dying that we've been able to achieve. And this, without realizing it, this could be a kind of follow-up to the individual experience that Felicia described, I would say before palliative care was well developed in Toronto. One other thing is we developed an approach, a structured approach to help people with the psychological problems, how to talk to their doctors, how to address the changes in themselves and the dependency in relationships that occurs, the sense of meaning, and the fears of the future. We've now been training people in China, Taiwan, Italy, Portugal, the United States, many other places, in how to do this. And the psychological skills are equally important as well as the skills in treating pain. We have a project actually, Tom, now at University College in London as well, trying to train nurses in delivering this intervention. So I just want to say one more thing about the quality of death and dying. There are some ways to assess it. We have used this tool. It's very hard to ask people in the middle of dying how they're finding the experience. But it is possible to ask their caregivers afterwards. This is a semi-structured interview. The Quality of Death and Dying questionnaire. It involves 31 items. And it addresses such issues as their satisfaction with symptom control, to what extent they were prepared for death, their sense of connection to others, and transcendence. And that really means to what extent they can approach the end of life without fear. And people do have fear of dying. And there has been a conspiracy of silence. People were afraid to talk to patients and families about the fear of death and dying. And this is what we found. I'll just explain the graph. These are scores from 0 to 100. 100, the best scores in the green is refers to a good or almost perfect experience, and the red to an acceptable experience, and the blue to a poor experience. So if we look at this graph, this shows the total scores. All of the patients, these were 400 patients, 400 caregivers who were asked about their patients' experience at the end of life. All of them said care was good, at least good or acceptable, and some said it was almost perfect. The two areas in which there were still difficulties were in symptom control and in transcendence. And this is a question for us to address, although the overall scores are extremely high. And I think they have to do with the availability of palliative care. 83% of this population receives specialized palliative care. What's interesting is that although there were somewhat better scores for home deaths, actually the scores overall were high. And of course it's not a fair comparison because more complicated deaths end up being referred to hospital, which says to us that actually we need a continuum. We need home palliative care, we need residential hospices, and we need specialized palliative care units. And for people dying in hospitals and nursing homes, we need also good palliative care. So I think this is a different experience than what Felicia described 15 years ago. And on that note, I'm going to stop. Just to say that palliative care has to do not only with the treating of symptoms, but the treating of human beings. It's not only a human right, it's a treatment for human beings. This patient said, referring to palliative care, this has been the only opportunity for us to be looked at as people by the medical system. I think that is really important because you are more than the sum of your parts. It makes me feel like I will be able to handle death in a peaceful way. And this may sound like a very radical idea, but this was actually known a long time ago. These are the words of Plato, who said that the greatest mistake in the treatment of diseases is that there are physicians for the body and physicians for the soul, although the two cannot be separated. And I think this is the message of palliative care. Thank you.
Gracias, Gary, por compartir las experiencias de Canadá y de Toronto. Los excelentes avances continuos, queremos seguir ese ejemplo.